or quite a bit about the small practice setting. So next slide. So really this is kind of what the literature shows and the movement shows, that there are really 4 main ways that healthcare can help. However, within each of these, there are many smaller steps and components. So our follow-up webinars will be addressing really how to do these things and what these things mean. So for today, we're just going to give a quick overview of them. All right, next slide. So I really love this quote, right? The body must be treated as a whole and not just a series of parts. I love it because it sums up both what we need to be striving for and also what we've done in healthcare, which is really the exact opposite, right? We've taken people and their bodies and completely compartmentalized them into organs and systems that run and function on their own. Trauma-informed care, which is person-centered by nature and by design, brings us back to this framework, which obviously holds that brains, bodies, systems, and experiences are all interconnected and all affect one another. Next slide. So many of you have seen this definition from SAMHSA, so I'm not going to, I'm not going to really spend much time on it, and we'll just go to the next slide for the framework, which can be referred to as these 4 R's, which is helpful in trying to remember. So trauma-informed care is care that realizes the prevalence of trauma and understands that recovery is possible. And Angela talked a lot about that, about understanding that recovery is possible and how common it is. It's care that recognizes the signs and symptoms of trauma in patients and staff. And this is really key that staff is included. We always talk about the fact that you cannot be trauma informed, and we try to talk to leaders about this for your patients, if you're not trauma informed for your staff as well, and potentially first, although it probably could be done around the same time. So it's care that responds by integrating knowledge of trauma into policies and practices. And the last one is something that I feel is really, really key, and something that at a minimum that we should be doing in healthcare is resisting the re-traumatization. Healthcare by nature can be re-traumatizing. So I feel like at a minimum, let's try not to re-traumatize people. Next slide. So because healthcare can be re-traumatizing, we often see its manifestation more than in other helping organizations or helping professions. And some is our fault, meaning that it's healthcare's fault. So I'm thinking, there's so many current examples. Where do we begin and stop? But I'm thinking about the forced sterilizations that we heard about that happened at the border, right? So this is certainly going to leave a scar and an impression, and is traumatic. And how are those women and their families going to respond when they interact with the American healthcare system again, right? What are those behaviors that we're going to see, and then how are we going to deal with them? So next slide. So I said that healthcare is inherently re-traumatizing, unfortunately, and it is. So here's just a few examples of how. This lack of control or understanding of what's going to happen. So we go into the doctor, many of us not really knowing what's going to happen or what could happen or what they might tell us. So this is really hard for anyone, but obviously for trauma survivors, it's even harder. Our bodies are constantly being touched and examined, right? We're poked, we're prodded. Sometimes it's gentle and sensitive, but sometimes it's not at all. There are invasive procedures, exams, shots, right? We often have to have invasive procedures that really make the toughest of us feel vulnerable and deeply uncomfortable, right? Bright lights, very sterile environment. This is kind of self-explanatory. Closed doors, right? What happens behind those doors? We understand perhaps that it's for privacy, but it can feel different to different patients. Use of electronic medical records while talking to a patient, right? It can often be this like, where is this information going? What is it being used for? Or is this person even listening to me? Masks, right? So before COVID and especially now, we can't see people's faces. We don't know exactly, we can't read them. There's a perceived lack or an actual lack of privacy, perhaps in waiting areas. Clinics and certainly hospitals can be confusing to find our way around, right? Sometimes we feel trapped. We don't know, how to get out. Music choices, what's playing in the waiting rooms and in the exam rooms. Having to retell our story, or never being able to tell our story, being cut off all the time. So these are just a few examples of how healthcare can be re-traumatizing. Next slide. So obviously we have to add this piece in around COVID because it's something that we've gone through as a group, but also depending on our COVID experience, it can be perceived differently. So the masks, Angie and I spent a lot of time talking about the masks. They're necessary, we all agree they're necessary, but they really are scary, right? We can't see people's faces. We don't really know who is behind that mask. Is it really the nurse that I usually see? I can't recognize people that, I can't recognize neighbors sometimes when I see them in their masks. Our temperatures, right, are taken without explanation. So we enter a healthcare setting and many other settings for that matter, and immediately someone aims a thermometer at us. It can feel like a gun or some sort of weapon. And there's this assumption that we all know what it is and why it's being used. I've been reading a lot that taking temperatures is basically useless. So do we really need it? Or is there a better way to go about it? That's a different discussion. I get carried away. And it's in front of everyone, right? What if someone has a fever? It doesn't mean that they have COVID, but immediately that's going to set off alarms. We're going to be judged, perhaps embarrassed in front of everyone. And then what? We don't get the care that we might need at that moment. So we're often allowing only the patient now to come in. What does this mean for people who are disabled? What does this mean for people who really need a support person there for anxiety, for fear, right? Sorry, guess not anymore. So next slide. So here are really the ingredients of trauma-informed practices. Communication, right? Sharing this information widely, discussing it at meetings, making it part of how we operate. This is a great first step. Engaging patients, if possible, in planning to be trauma-informed. They can offer amazing and insightful feedback about our services and how they experience them. We should ask them, we should use them. Many of them, some of them may not want to, but many of them might, and they might be flattered. Training all staff, right? This is key. Everyone needs this information, from the security person, and definitely the security person, if there is one, all the way to the physicians. This is not information for only clinical staff. Creating a safe environment for staff and patients. We'll discuss again what this could look like. Preventing secondary traumatic stress in staff, another really important ingredient that we'll cover on another webinar. We must support our staff, many of whom had their own trauma or at least been involved in group traumas, and more so now than ever, right? We have all been through so much as a healthcare community. Let's see here. Building a trauma-informed workforce. This does not mean rehiring everyone, of course not. It means training and asking about how people will approach different situations in the interviewing and onboarding process, okay? Just gonna try to, all right, next slide. Okay, being person-centered. So the thing that's great is that trauma-informed care is by nature person-centered. And I always like to joke that these things like person-centered, trauma-informed, culturally responsive care, these are really all the same things. When we really look at them and what their core is, they are very similar. So if you're trauma-informed, you're gonna be person-centered, and you can kind of check that off. We have to screen, obviously. We'll have a whole webinar devoted to that, particularly around how small practices can get it done. We have to train staff in trauma-specific treatment approaches, right? We also have to, we don't have to necessarily be trauma therapists, but we certainly have to be able to refer out to places that do good work around trauma. And that really leads into these engaging our referral sources. We don't have to be everything, but if we don't know how to respond, we cannot screen. And I would say in all of the work that I've ever done around screening for things like intimate partner violence and depression and now trauma, the #1 reason that people say that they don't want to screen is that they don't know what to do when a screen is positive. So that is a real concern, and we're gonna tackle that. Okay, so let's go back, next slide.